Good morning, everybody. I'd like to discuss the topic of damage control laparotomy, and I've based this presentation around the relevant chapter in the 12th edition of the textbook Current Surgical Therapy, and I'm happy to recommend this as a reliable source of information to you. And with that in mind, we aim to define damage control surgery whilst concentrating on laparotomy only, discuss the importance of the lethal triad and how crucial it is before surgery, during your operation, and also down in the intensive care unit. We'll discuss the principal control surgery, and we'll also introduce a 4-phase approach on how to undertake damage control surgery as well. So the take-home message from today, I hope, will be that the overriding aim of damage control surgery is to save the life of your patient. To do this, postponing non-essential surgical tasks and performing life-saving surgery only is the key to success. The underlying concerns are that your patient can rapidly develop what is referred to as a lethal triad. I recommend that you become very familiar with this term and understand what you can do to address it, because if this occurs, then mortality is in excess of 90%, regardless of your operative intervention. We should always be thinking about hypothermia, acidosis, and coagulopathy, and what we can do to address and prevent all three things from happening. This is a hot exam topic for FRCS. So in short, targeted life-saving surgery is how we can help prevent the development of the lethal triad. Adopting a mantra of normal physiology is more important than normal anatomy, and this will save lives. As surgeons, we have in the past been guilty of thinking that only performing surgery will save the life of the trauma patient. However, the principles of damage control surgery go well beyond this, and as surgeons, we need to be familiar and comfortable with a team approach to damage control surgery. The principles are as follows: hemorrhage cessation, control of contamination, maintaining perfusion of vital organs. Following life-saving surgery, we need to recognise the importance of resuscitation in the intensive care unit, with the aim of restoring normal physiology before embarking upon definitive surgery at a later date. In order to save your patient in the trauma setting, then the following recipes for success should be adopted. There should be early recognition of altered physiology, which results in early damage control surgery. You also need to have adequate intensive care unit capacity and the resources available. And crucially, you need to have readily available blood and products. However, we also need to be mindful that damage control surgery is resource intensive, and it consumes lots of operating time, intensive care resources, and personnel. So there's a 4-phase recipe for damage control surgery. Phase 1 is early assessment in the emergency department and recognition of the need for damage control surgery. Phase 2 is undertaking damage control surgery itself. Phase 3 involves taking the patient down to the intensive care unit with the aim of restoring normal physiology before returning to theatre and performing Phase 4 definitive surgery. So if we take each of these phases in turn, Phase 1 occurs in the emergency department. It begins with the Advanced Trauma and Life Support Primary Survey and A to E approach that we are all familiar with. The easiest, quickest, and most reliable vital signs to look at are the blood pressure, heart rate, and temperature. The best indicators for the need to perform damage control surgery are as follows. If there is a penetrating mechanism of injury or a positive FAST scan, plus a systolic blood pressure less than 90 millimeters of mercury, or a heart rate greater than 120 beats per minute, or a core body temperature of less than 34 degrees Celsius. Whilst in the emergency department, hemorrhage control can be obtained early by applying direct pressure over a bleeding wound or the application of a tourniquet where appropriate in order to facilitate a rapid primary and secondary survey. Damage control resuscitation always begins in the emergency department, and this requires large bore IV access. It's essential that the fluid of choice should always involve the early use of packed red cells and fresh frozen plasma, and these should be delivered at a ratio of 1:1. The massive transfusion policy should be activated early, with the aim of maintaining cerebration and a systolic blood pressure in the region of 70 to 80 millimeters of mercury. The following measures will also help, and these include warmed blood, removal of wet clothing, application of warm blankets, and the early use of warmed oxygen and air warming devices such as the bear hugger. And those who have multi-system injury, surgical interventions should be prioritised with good communication between the surgical and anaesthetic teams. So moving on to phase 2 and performing damage control surgery. Before embarking upon the surgical intervention, there should be a brief pause to determine the order of intervention for any multi-system injuries. The decision to perform damage control surgery should be made early and ideally before knife to skin takes place, with all staff members in the operating theatre aware of the proposed plan for your patient. The decision to perform damage control surgery should not be made 3 hours into your procedure. In addition, the temperature in the operating theatre should be turned up. All non-operated body parts should be covered up and warmed with heated air. There should be warmed gases, warmed intravenous fluids, and warmed irrigating fluids throughout the procedure as well. So in this presentation we're concentrating on damage control laparotomy. During laparotomy, the first priority is with hemorrhage control. So entry into the abdominal cavity is gained by a full-length midline laparotomy from xiphisternum to pubic symphysis. This will enable maximal access to the abdominal cavity. Once this has been achieved, large clots are evacuated, and if the situation determines that the abdominal cavity is welling up with blood, then one option is to occlude the aorta. This can be achieved in a number of ways, with your fist placed over the aorta and pressure applied at the esophageal hiatus, and then a sponge stick applied to maintain this pressure. Or, if the situation allows, then an aortic clamp can be applied in the same area. The next step is systematic packing of the abdomen in a 4-quadrant fashion. The exact order is determined by the environment in which you find yourself, but by the end of the packing process, the liver, spleen, and pelvis should be well packed. Once this has been achieved, you should inform the anaesthetist and establish vital signs. During this pause, the anaesthetist may wish to take the opportunity to catch up with blood and blood products. Once hemodynamic stability has been achieved, and the anaesthetist is happy, then the packs should be withdrawn in a serial fashion with hemostasis of any bleeding points identified. If we look at hemorrhage from the liver specifically, in the presence of uncontrollable bleeding, then Pringle's manoeuvre should be performed, and this is demonstrated in the diagram. This is a manoeuvre that you should all be familiar with and able to perform in the emergency setting. If this is not feasible, then targeted packing around the liver to obtain a compressed, anatomically normal liver should be undertaken. When packing next to the vena cava, you should pack adjacent to it in such a manner so as not to obstruct overall venous return. Visible bleeding vessels should be ligated and clamped. If you're dealing with gunshot wounds or penetrating injuries, then a balloon tamponade can be used to control diffuse bleeding with a Foley catheter. In the situation where you have hemorrhage from the retrohepatic vena cava despite the application of Pringles, then primary suture repair or liver packing should be the means by which you deal with this. Dealing with bleeding from other specific organs, if there's bleeding from the spleen, a splenectomy should be performed. If there is evidence of bleeding from the kidney, non-expansile hematomas should be left alone. If there is active bleeding from the kidney, then you should perform a nephrectomy, bearing in mind that you should look out and check the size of the contralateral kidney, if possible. And in bleeding from the pancreas, hemorrhage can be controlled with ligation of the superior mesenteric artery and superior mesenteric vein branches. In terms of dealing with vascular hemorrhage, we divide vessels into being large vessels. Small vessels include mesenteric vessel, the inferior mesenteric artery, the celiac plexus, hypogastric, and the inferior vena cava below the kidneys. These should just be clamped and ligated. All of the larger vessels, these include the superior mesenteric artery, superior mesenteric vein, portal vein, suprarenal, inferior vena cava, and iliac vessels. They should be directly suture repaired or a temporary shunt placed. And the abdominal aorta should have a direct repair or a shunt using a chest tube, and there are various videos that are available on YouTube for watching this. In the presence of a pelvic hematoma, this shouldn't be disturbed unless it's seen to be expanding in size and overlying an iliac artery. Having obtained control of any obvious hemorrhage, the second priority is to deal with contamination. This requires the identification of any sources of gross spillage and sealing these temporarily with a Babcock. You then make an assessment of the injury to the bowel, and a suture repair can be undertaken if the laceration is less than 50% of the circumference of the affected area. More destructive areas or multiple injuries that are in close proximity to one another, these are most easily dealt with by resection with a stapling device, and it cannot be emphasised enough that in the damage control setting there is never a role for undertaking an anastomosis or indeed a stoma, and if it is necessary to resect any bowel, then the two ends should be stapled off, returned to the abdominal cavity, and temporary closure performed. the authors of the text I referred to earlier make specific mention about irresectable duodenal injuries, and they suggest that if you encounter these, then these duodenal injuries should be reinforced with a direct suture repair with a loop of small intestine called a thal patch used, and the insertion of multiple drains to control any spillage. Priority 3 in damage control laparotomy involves gross debridement and removal of foreign bodies, and this is relatively straightforward. Necrotic bowel should be reflected with an appropriate stapler, and large amounts of dirt and foreign material and any obvious necrotic tissue should be debrided. The final phase of your laparotomy is to perform a temporary closure. The closure should always be temporary, as there will always be a need to return to theatre within 24 to 72 hours. The aim of your temporary closure is to achieve a temporary closure which prevents abdominal compartment syndrome and preserves fascia for future definitive closure. And there are three main options that are open to you. The first is a Bogota bag, and this is further information on this is widely available on the internet. The second is the more modern negative pressure VAC systems, and there are now commercial kits that are available, and we have them in Ninewells Hospital. And finally, you can compose your own, and this is simply made of a fenestrated layer, such as an intravenous bag, which is opened up, placed atop the bowel, simply sutured in place, sterile towels placed on top with 2 suction drains, and then an Ioban over the top, and that seals and occludes your abdominal wall. So the image in your top right hand corner is a Bogota bag, and the image in the bottom right is the negative pressure VAC system that has been applied. So with completion of the damage control laparotomy, there is a need to move on to phase 3 of damage control surgery, and this is a key stage. At the end of the laparotomy, there should be a clear documented plan and clear verbal communication between the surgical team and the anaesthetic team as to the aim of returning to intensive care, with a view to outlining a plan for return to theatre and undertaking phase 4 definitive surgery. So intensive care resuscitation involves addressing the reversal of the lethal triad and instituting measures to return to normothermia, address any acidosis, and reverse any coagulopathy. There are a number of other considerations to make whilst down in intensive care. There needs to be a management plan for the temporary abdominal closure with appropriate analgesia. The patient is usually remains on a mechanical ventilator with appropriate muscle paralysis. If acidosis, hypertension, or coagulopathy worsens, then all members of the care team need to consider ongoing hemorrhage, contamination, or presence of gangrenous necrosis, and a prompt plan made for return to theatre. And whilst all of this is undergone in the intensive care setting, the patient needs to be monitored for the presence of developing abdominal compartment syndrome. Phase 4 is the final phase of damage control surgery and is labelled as definitive surgery. This is only to be undertaken when resuscitation is complete and normal physiology has been stabilised. It is not performed by the initial operating surgeon, so surgical documentation from the damage control surgery needs to be assessed with an appropriate verbal handover as to what damage control surgery was undertaken, and a close plan between the phase 4 surgeons and anaesthetist as to what is likely to be required during the definitive surgery. At the start of the definitive surgical procedure, a close inspection of the bowel needs to be undertaken to ensure that there were no injuries missed at the initial damage control surgery. So a comprehensive surgical re-exploration needs to be undertaken. If there are any packs left in situ, which is often the case, then lavage of the abdominal cavity and underwater packing removal is recommended, and this is to prevent hemorrhage being caused by removal of the packs. The authors of the text recommend that an X-ray is performed after pack removal to ensure that no packs are retained within the abdominal cavity. In terms of the definitive surgery, obviously this depends on what was performed during the initial damage control operation. It may well be just to ensure that there is no ongoing hemorrhage, and then definitive wound closure can be undertaken. However, if any bowel has been resected with the two ends popped back inside, then clearly a plan needs to be instituted to either restore bowel continuity or perform appropriate stomas fills. So, in summary, in this presentation, I have tried to cover the theory and principles behind damage control surgery, whilst concentrating on performing a damage control laparotomy. And the take-home messages from this presentation are that an early decision should be made to perform damage control surgery, with institution of resuscitative measures being taken immediately. A recognition of permissive hypotension, limiting the use of crystalloids with the early use of blood and blood products. There needs to be a clear, open line of communication between the surgeon, anaesthetist, and intensivist in order to achieve the maximal outcome. A stepwise approach outlined in this presentation should be used in the trauma setting when damage control surgery is being undertaken. Maintenance of normothermia is one of the key factors in ensuring the best outcome of your patient, and addressing the lethal triad is absolutely crucial. I hope you found the presentation useful. There's a whole plethora of information available on the internet about damage control surgery. Going into further detail about the lethal triad is probably beyond the scope of this presentation, but in terms of understanding as a surgeon of the lethal triad, it's a key FRCS exam topic for the critical care scenario, and I was asked about this in quite a lot of detail at my recent exam, and you definitely need to have a good understanding of this. Thank you.